All, this is Dr. Mobeen Sayed from Drbeen.com. Welcome to one more show. There has been a lot of discussion about multiple sclerosis, use of ivermectin, and then multiple sclerosis and taking the vaccine or not taking the vaccine, or any issues related to COVID and vaccines and medicines. So what I thought was that let's go over, just like we did with the Epstein-Barr virus, let's go over what is the multiple sclerosis, how do we manage it, what is the pathology, then we can connect it to our understanding with the COVID as well. So this would be a two-part talk. Today we'll talk about the clinical aspects and a summary of the disease, multiple sclerosis. Tomorrow we'll go more in detail for the pathology, because I want to make sure that the blood-brain barrier possible damage or inflammation of it is clearly understood by all of us, so we can understand for the drugs usage and the vaccines possible effect. So let's start our discussion. The quick sharing of the websites that I've used are the following. So this is drbeen.com. Most of these videos end up on drbeen.com. This is Mayo Clinic for the multiple sclerosis diagnosis and other management techniques. This is also Mayo Clinic for management. This is Wikipedia about interleukin 2 receptors. Again, if you wanted to read it from somewhere else, you could. This is National MS Society and some information over there. This is also the same society's webpage and the information about the diagnosis. So I'm going to take these down and just start with our illustrations. For the books, this is the Robbins Pathology 9th edition, and I also have the Current Medical Diagnosis and Treatment 2016 Lange. So these are the books for reference, and let's start a discussion. So first of all, summary. It is an autoimmune disease. That means we really do not know what is the cause of this. It is possibly environmental, possibly there is a genetic predisposition, and then it is also seen that sometimes infections can trigger the multiple sclerosis or make it worse or cause a relapse. So that is the basic definition of it. It's a disease, it's a demyelinating disease of the central nervous system, and it is progressive. That means it continues on, it does not slow down, it does not stop, it is progressive, and it is a disease of central nervous system. Central nervous system means brain and spinal cord. All the nerves that come out of the brain or spinal cord, except optic nerve, are called peripheral nervous system. Optic nerve and olfactory bulb, both of them are actually extensions of the brain tissue. That is why they're not taken as a peripheral nervous system. The basic pathology, when the attack occurs in this disease, the cells that are more active in causing the damage, the immune system cells, these are T helper 1 cells. And you know that T helper 1 cell can lead to cytotoxicity. T helper 17 cells abnormality. That means the regulatory T helper cells are not able to regulate correctly, and that can cause inflammation and increase in inflammation in the brain. In addition to that, the effector cells, the cells that actually cause the damage, are macrophages. Macrophages will go and kill the oligodendrocytes or damage the limbs of the oligodendrocytes. Oligodendrocytes are the myelin cells of the central nervous system. We know that for peripheral nervous system, the nerves that are, for example, coming out of my spinal cord and going to my fingers or my muscles or my skin, these are covered with Schwann cells. They make the myelin sheath for the peripheral nervous system. For the central nervous system, the cells that make myelin sheath or the protective covering and the covering for the rapid transmission of the nerve signal, these cells are called oligodendrocyte. One oligodendrocyte can give off 50 branches that can wrap around multiple axons or multiple neurons. So it is not necessary that one oligodendrocyte is covering one. It can actually be covering many, many cells. So if an oligodendrocyte is damaged, then it is possible that a lot of axons will lose their covering and will not function correctly. And that is one part of the primary issue with the multiple sclerosis. So macrophages are the effector cells. They're the one that cause damage. They are the one that kill oligodendrocyte or damage them. In the US, I think it is 1 in 100,000. I think I wrote 1,000 here. That is incorrect. In the US and Europe, it is more prevalent. I think 1 in 100,000. Women have 2-to-1 ratio with men. So twice as many women. Women generally have more autoimmune diseases. Usually the age of a patient is lesser than 55 years of age. Most of the time, this disease starts between 20 to 40 years of age, and mostly women. It is a disease that causes relapses and remissions normally. And we'll talk about the types of the classes of this disease. So there are some types of this disease where there are no remissions, there are no relapses. It's just one continuous progression. We'll see that today. The summary of pathology. The summary of the pathology is the following. Inside the brain, so let's start from here. There is a neuron. So this black dude here, this is a neuron. This neuron is covered, if you see here, the myelin sheath on it that makes it white in color, look white in color. If you see, there are two cells. This is one cell which is called oligodendrocyte, and this is another cell called oligodendrocyte. These are the supporting cells of our brain. Their function is not only to cover the axons, their function is actually to support the axons as well, to be in their place, to give a structure to the brain tissue. They also keep the brain tissue from collapsing into each other. So they kind of make padding and cushions and support as well. So they're very important cells. Oligodendrocyte, as I said before, one oligodendrocyte can give up to 50 axons, 50 branches. Each branch can make a part of the myelin sheath on one axon. So it is not necessary that one oligodendrocyte will cover one axon only. It could cover more than one. Now, what happens really in the pathology? There is some issue inside the brain, autoimmune issue, unknown cause, but there is some inflammation starts. When the inflammation starts, then what happens is that the immune system cells try to cross the blood-brain barrier and enter the brain tissue. So in the beginning, the blood-brain barrier of the patient is strong and it is intact, and so it is difficult for the cells to reach the brain. But as some cells squeeze through the blood-brain barrier and enter the tissue, they will then go there and start releasing cytokines. For example, interleukin 1, interleukin 2, interleukin 17, and so on. When those cytokines are released, then these cytokines, here in this diagram, these black dots, these cytokines not only cause local inflammation, but they also cause the blood-brain barrier to start opening up. So they would actually cause inflammation and opening up of the blood-brain barrier. This actually has two very important things for us to keep in mind. Those drugs that cannot be used when a person's blood-brain barrier is compromised, for example, ivermectin, they cannot be used by a patient of multiple sclerosis when that patient is in active relapse or active acute disease, because at that time their blood-brain barrier is actually damaged or inflamed. The second important thing is that when you have a patient of multiple sclerosis and you do their MRI and you look at the blood-brain barrier's inflammation, then you know that this patient is undergoing new lesions, new pathology, new damage. When the patient is outside of the relapse, their blood-brain barrier would heal because the inflammatory cytokines will go away. And so patient will become normal. If you take their MRI at that time, there will be no inflammation of the blood-brain barrier. So blood-brain barriers damage and swelling and inflammation is important for two reasons here. So now when the cells have entered the brain tissue, then they have acted on the blood vessels and caused the blood-brain barrier to open up. That would allow more cells to enter this place as well, the brain tissue. Now, what are the kind of cells that come in? T helper 1s come in, T helper 17 arrive. T helper 17 always arrive because their function is to calm down the inflammation. But here in these patients, these T helper 17 are not able to calm it down in time or at all. The result of that is that the T helper 1 would stay active, plus there are B cells that would arrive. They will start making antibodies. Normally, we do not want the B cells to come in the brain and start making antibodies, but they do in the case of an acute attack of MS. In addition to that, macrophages are brought in as well. Macrophages will always go to the area of inflammation because their function is to cause repair. Their function is to remove debris. Their function is to remove cells that are damaged or infected. So macrophages would come in here as well. Now what happens is, unfortunately, that the B cells that arrive here, they start making antibodies against proteins in the myelin sheath. So the oligodendrocyte, imagine oligodendrocyte is like an octopus and it has 50 arms. And those arms wrap around people's arms, let's say axons, the neurons. And the antibodies generated by the B cell attack these arms of the oligodendrocyte, of this octopus. As they attack and they bind to the protein present in the myelin sheath, macrophages look at that and say, I need to kill the cell on which antibody is sitting. So if you see here in this diagram, down here, this is a macrophage that is attacking a myelin sheath covering on an axon because this covering was coated by the antibodies produced by the B cells. The result is myelin sheath or one limb of the oligodendrocyte will be damaged. So in the beginning, oligodendrocytes do not mind that. They will regenerate their myelin sheath, they would regenerate their limb, and they would wrap the axon again. But if you continue to damage them, eventually there'll be so much damage that they cannot repair and regenerate correctly, and they would die away. When they will be dead, then on the axon there is no myelin sheath, so the nerve impulse travel would slow down, number one. Number two, there would be scar formation in that area, which would further irritate or block the nerve's function. So that is the basic pathology. Which cells are bad here? T helper 1, T helper 17, B cells, and macrophages. That means when you are thinking about how to manage these patients, what are you going to do? You are going to reduce the function of the immune system. What are the things that do that? Corticosteroids do that. Then you might find specific therapies that would attack these antibodies. You might find specific therapies that would stabilize the blood-brain barrier so it does not allow the inflammatory system cells to enter. You might give specific therapies against cytokines, so cytokines do not act on the blood-brain barrier and they do not make it inflamed. So there are multiple ways. Then as the patient develops symptoms, you might have to give medicines to help with those symptoms. So let's continue. This is the quick summary of the pathology. Diagnosis. MRI is a very important thing. With the MRI, T1 weighted or T2 weighted, with the T1 weighted, you can see the lesions present in the brain. With the T2 weighted, You can see the active disease and overall disease, how much damage has occurred. You can see that. And is there any new damage that is occurring? You can do that. So T1 weighted and T2 weighted MRIs can be done. CSF studies are done because there are more immune system cells that has entered the brain. It is possible that some lymphocytosis means increased number of lymphocyte or white blood cells in the CSF, that might be seen. There would be some increased proteins in the CSF because immunoglobulins, or the antibodies that are being formed, are proteins. So when you take the CSF and you test it, you might see some extra proteins. We'll talk about that. Then you can look at the clinical picture of the patient. Then the evoked potential tests. So you could, for example, add an electrode on a nerve and then try to activate it with an action potential and see the result of that. So evoked potential tests can be done. Blood tests can be done to rule out other possible diseases. Again, this today we are looking at summaries and clinical side. Tomorrow we'll look deeper into the pathology and the blood-brain barrier compromise. Management, as I said before, corticosteroids are important. Plasmapheresis is important. What does that mean? You take the plasma out of the patient. So you take the blood out from the patient. It's a continuous movement of blood from the patient to a machine. In the machine, you separate the blood into plasma and cells. You remove the plasma of the patient that also has antibodies and cytokines in it. You add 5% albumin with the cells and put them back in the blood, in the body, and that is how you remove antibodies. So plasmapheresis or plasma exchange can be done. It is also interesting to see that recently it is thought that vitamin D's levels, if they are low, they predispose the patient to have acute attacks of MS. So vitamin D correct levels seems to be a good approach as well to help with MS. And this is also why the multiple sclerosis patients are mostly in the areas where there are temperate temperatures or cooler temperatures, where sun is less or exposure to sun is less. That means vitamin D levels are less, and those belts actually have more patients of MS. In addition to that, other drugs for various disease types are given. So if you can see here, ocrelizumab is given. Then there are, for the relapsing-remitting disease, and we'll talk about the types today, interferon betas are very important that are given. Then there are other drugs that are given, oral or infusions or injectable. Now, this is important that you would also have to manage the patient for their signs and symptoms that are occurring because of the nervous myelin tissue damage in the nervous system. So you may have to ask the patient for physiotherapy. You may have to give them muscle relaxants. Why do we give muscle relaxants? What happens is, as the nervous system's covering on the axons in the central nervous system, those coverings are damaged. The function of the nervous system becomes uncoordinated, number one, and number two, unexpected. The nerves can start firing on their own, just like electrical wires can become short circuited if there is no covering on them. So now imagine two nerves that are going to function together at the same speed. Now, one of them is not functioning at the correct speed or not functioning at all. Or it was not supposed to function and it just started functioning. All of those cause discoordinated nervous tissue function, which means the patient may have unexpected motor activity, they may have unexpected psychological or mood activity, they may have unexpected sensory feelings. or sensory perceptions. So you may have to give them medicine to manage all those signs and symptoms that are occurring. So physical therapy, muscle relaxants, fatigue meds that can help improve the fatigue in these patients. There are some meds that can help improve the speed of walking, very tiny change, but still. Then medicines for depression, pain, sexual dysfunction occurs, so medicine for that. Urinary incontinence occurs, bladder incontinence, fecal incontinence occurs, um, other dysfunctions of the muscles occur, so they need to be managed as well. Now, some more details. Number one, age is usually lesser than 55, and as I said before, women are more prone to this disease. This disease has multiple types. So, normally, what happens is early on in life, let's say 20 years of age, 23, 24, patient might get an attack of multiple sclerosis. So there may be some part of the brain and the myelin sheath that would become inflamed. And the patient might come to you to say, I cannot see correctly. So there might be neuritis that would occur. So they may say, I'm seeing double, diplopia may occur, or nystagmus may occur. Their muscles of the eyes will not be in sync with each other, and so there may be tremor in the muscle. There may be tremor of the hands. It is not that the peripheral nerve is damaged, it is actually the controlling systems for these nerves, the central nervous system controlling system, brain and the spinal cord tissue, that is not functioning correctly. They may come for the first time with urinary incontinence or pains or burning sensations. Very often they start with the optical issues or urinary incontinence or uh, or uh, difficulty walking or performing functions or sensory paresthesias. Paresthesias mean incorrect sensation, does not mean less sensation or more sensation, it means incorrect sensation. For example, once I had picked up the firewood and I threw my back, and I had some of my nerves pinched, and I started feeling strange tingly feeling and burning feeling where I had never felt like that in my leg. So that is a sign of or an example of paresthesia. Now, normally what happens is the types of multiple sclerosis. Normally what happens is that there is an attack, then it is possible that for a year or more, there is no further attack at all. And then there is another attack. And then there is another attack. So this is called relapsing and remitting disease. There are hills and valleys of signs and symptoms. And in the beginning, they are set apart by months and years. This is why if you have a patient who you think may have multiple sclerosis, but their multiple sclerosis is in very early stage, maybe this is their first attack, and by definition you have to have multiple attacks, or MRI has to show the damage plus CSF, so you cannot define them as or diagnose them as MS. In this case, you could call them clinically isolated syndrome of MS, or you could say they have CIS, beginning of the MS, and you could start them with the medicines that would delay the second attack by years, and that is how you would try to slow it down. So please remember, one important aspect as a healthcare professional is how do you start thinking that is this MS? Imagine you have a patient and they have some neurological deficit, they have some neurological abnormality, and you're thinking that where in the brain there may be damage, and various parts of the brain, when they're damaged, there are distinct signs and symptoms of those. But you're thinking and you're saying, well, the symptoms that this patient has, they do not look like coming from, let's say, motor area or personality area or the sensory area or the optic area or the auditory area, or from the brain stem. Instead, the symptoms are so diffused and varied that you feel there is more than one area of the brain that is involved. So, as soon as you reach the thinking that the symptoms are such that any one area and any one kind of lesion cannot explain them, then you are going to start thinking about multiple sclerosis. Now, as I said before, it is seen more commonly in the cooler temperatures, so temperate areas. So we have equators at 0 degrees, then we have tropics, warm areas, and subtropics, relatively warm. Then we have temperate areas, cooler, and then frigid areas on the poles. So this disease is more prevalent in the temperate areas, and one connection is lack of vitamin D or less vitamin D in these areas. That is why it is important to keep your vitamin D levels correct. Now, continuing, the genetic predisposition, and I had one more part of this discussion. Let me just see. I want to see the, yeah. So I'll do more classification a little later. Genetic predisposition. So again, there may be some environmental factor. It is an autoimmune disease. It is a disease of unknown etiology. We do not know what causes it, just like many other allergies. So it may be environmental in its trigger, or there is some genetic predisposition. And what is seen is that HLA-DR2 antigen and IL-2 and IL-7 receptor antigens, these are all related to immune system function. So these antigenic alleles could actually, not antigenic, but these immune system related allele could create a genetic predisposition. And we'll see more in detail tomorrow with the pathology. Now, what is the clinical picture? Let's start from head to toe. Normally, the very first signs and symptoms are optic neuritis. So that means retrobulbar, behind the bulb, behind the eye, the nerve, optic nerve becomes inflamed. Because of that, there may be visual disturbance, there may be diplopia, double seeing, there may be nystagmus, movement of the eye, and because the muscles are not working correctly. There may be dysarthria, and that is the person cannot speak correctly. The person may have laughing or crying spells. And why is that? The reason is very simple. Just like in paresthesias, a sensation of burning or tingling or prickly feeling would just appear out of nowhere. Just like in COVID nowadays, some people say that I smelled, let's say, coffee at some point 6 months ago, and I still smell coffee. Or some folks would say, I smell weird things which are not even around me. These are phantom smells. And why are they smelling phantom smells? Because their olfactory system is triggering without actually any smell around. And when the olfactory system shoots the signal to the brain interprets that as some smell. Similarly, when the brain tissue, which is functioning with the facial expressions, when that tissue misfires, the patient might make a face that looks like they're laughing, or they might create an expression that is of crying. So it could be a mood imbalance, and it could be a structural messaging which is incorrect. Bowel and urinary incontinence occurs. Many times patient actually comes to you with the urinary incontinence. Sexual dysfunction can occur. That can occur for two reasons. One, direct autonomic nervous system's malfunction, or two, maybe not the direct autonomic nervous system's malfunction, but patient being too tired, too depressed, too anxious, and really not feeling like having sex. So their drive and desire reduces. A third reason can be the sensory paresthesia. So the genitalia that are responsible for sexual physical sensation, they may not provide the correct sensations as well. So sexual dysfunction, weakness of the muscles. So it is really not the muscles that are weak. It is also not this peripheral nerve that is incorrect. It is the firing of the system from the brain to the spinal cord and outwards. Numbness, that is the reception of the sensory stimuli all the way to the brain, and that is, these are not working correctly. Tingling, burning sensation, disequilibrium or ataxia. And what is that is, when we are walking, or when I'm sitting like this, I'm sure that you are sitting, lying down, standing and watching, or walking and watching, or listening. Our body keeps our body's posture in this shape, whatever shape you have assumed at this time, by maintaining the muscle tones that would create this shape and maintain it. If our body cannot maintain the muscle tones correctly, that would create tremors and unexpected movements. And when the patient is actually going to try to walk, their muscles will not be correctly coordinated, and ataxia would occur. Ataxia means inability to walk straight. So, disequilibrium, ataxia, sensory and motor disturbances, autonomic nervous function disturbances. Now, types. So, in the beginning, the patient starts, the very first attack, for example, will create some inflammation in the nervous system that would create an attack and some sensory or motor malfunction. Then what happens is there is a there is a remission, and that remission stays on, let's say, for some time, maybe a year. Then a relapse occurs again. Now, with each attack, patient does not become 100% corrected. There is some residual, some remaining damage that is left. There are some cells that are damaged, oligodendrocytes. And so, with each attack, there is some abnormality that is left as a reminder that this was an attack. Then, what happens is, as the time passes, the number of attacks and the duration between them, number of attacks increase for a given period of time, or duration between the attacks reduce. So more and more attacks start occurring. Then their severity keeps increasing. Plus, the damage in the nervous system keep accumulating. Every attack leaves a scar. Every attack leaves some part of the myelin system, covering system, damaged. And as that continues to accumulate, patient would continue to accumulate more and more neurological deficits. This is called relapsing and remitting multiple sclerosis, or RRMS. There could be a time when this relapsing and remitting, so if you look at this graph, I forgot to say, this is a timeline, and this is the disability or the pathologies that patient is accumulating. So with time, there is more and more pathologies, but patient keeps relapsing and remitting. Then it is possible that a time comes when the patient does not develop remission, and one acute attack just continues to be the attack. So now the patient is in a continuous attack. Disability starts increasing continuously as well, because it is continuous brain tissue damage and it is not stopping. That would then become secondary progressive multiple sclerosis. What does this mean? Secondary means as a result of something else. So this is as a result of the primary disease. So this has become secondary. Progressive means now it is just progressing, it is not relapsing, it is not remitting at all, and multiple sclerosis. So that is SPMS. This becomes dangerous. In some patients, the initial relapse and remission pattern is never seen. It is a rare condition where the very first attack just continues to be the attack. and there is continuous inflammation, there is continuous blood-brain barrier damage, there is continuous myelin sheath damage, and there is continuous neurological deficit that continues to occur. This is called primary. That is, primary normally in medicine means the very first time. Primary, progressive. So right from the beginning, it is progressive. There is no relapsing and no remissions. So this is PPMS. And of course, we saw clinically isolated as well. So there could be clinically isolated, and there could be relapsing and remitting, there could be secondary progressive, and there could be primary progressive. Etiology, I'm repeating this part, not known exactly what happens. It is probably environmental factors. It is probably lack of or reduced vitamin D. It is probably triggered by infections, including nowadays possibly COVID. And interestingly, it reduces in pregnancy. The intensity of the relapses reduce, the number of relapses reduce, and the female actually feels better. However, about 2 to 3 months after the delivery, she has a greater chance of a relapse. And the reason for that is that after 2 to 3 months of postpartum, woman is under stress physically and psychologically. So she's taking care of a baby, she's taking care of her life as well. It is quite a stressful time. And that stressful time brings her immune system's activities out of control, and she can actually develop a relapse. Now, for diagnosis, imaging T1 or T2 weighted images are done. That is really frequencies of the waves. I saw a beautiful video about how these are calculated, so it is beyond my scope of explaining it. But T1 weighted and T2 weighted, the basic difference is T1 weighted MRI show us less water and more fat uh, tissue or fats in the tissue. T2 weighted also shows water. So what you do is you do T1 weighted and then you do T2 weighted, and you can see CSF and not CSF, and from there you can actually see where are the lesions if you wanted to see CSF as well, or the flow of the CSF. Here the T1 weighted images will show black holes, and that is the permanent axonal damage area. These are the plaques. We say that in multiple sclerosis, plaques or sclerosing areas or scarred area or damaged areas form. So you can see the plaques on MRI. In gadolinium enhanced T1 weighted, areas of inflammation and blood-brain barrier is seen. In T2, the overall damage of the disease burden or how much damage has become accumulated, that can be seen. For labs, CSF can be seen, but CSF itself is not sufficient. What will happen is it's actually very understandable because there are more white blood cells that are coming into the brain during an acute attack. There will be some lymphocytosis, but lymphocytosis can occur for many reasons. You have to combine that with the clinical suspicion, and then you have to get the MRI as well to be able to reach a diagnosis. But mild lymphocytosis may occur. In addition to that, there will be more IgGs. Of course, there are B cells that have come in, they are making antibodies. Those bodies are tagging the oligodendrocyte cells, and macrophages are attacking them. So, of course, antibodies are more, which are proteins. So, protein quantity in the CSF is increased. And there is a unique thing, and that is many patients have oligoclonal IgG bands. In addition to these, visual stimulation, so there is a checkerboard and patient has to follow that. So visual stimulation tests are done to see if the eyes and eyesight and the muscles, everything is working correctly or not. Mono-oral click stimulation, so ears can be tested with the click senses or sounds. Peripheral nerve stimulation can be done, either sensory nerve stimulation or a mixed nerve stimulation, and that can be seen. Pathology is the piece that I would go over tomorrow. So this is the discussion for today. What I want to connect this to tomorrow is the pathology, the damage to the blood-brain barrier. Can COVID exacerbate MS? One, when should we take vaccine in these patients, and what is the care with ivermectin if there is a patient of MS? So these are the discussions we will do tomorrow. Let me just quickly see if I can answer some questions. I thought I would do this in 10-15 minutes, and there is 40 minutes. So there is a question. M. Gregory says, can ivermectin help regenerate myelin sheath? No. Actually, ivermectin causes brain tissue damage, and it is not supposed to be taken if there is a blood-brain barrier damage going on. In some patients, ivermectin can cause permanent brain damage. So not at all. Ivermectin is not a good thing for brain. So Walking Tall says, I recently saw a video where they were saying that MS is actually caused by tapeworms. This doctor did autopsies on several patients who died with MS and found tapeworm larvae in spinal fluid. So again, as we do not know exactly what is the etiology, we do think that infections can trigger MS. And as we'll do the pathology tomorrow, you'll see the mechanism of the pathology, and you could actually think for yourself that how those cells could be triggered. So tapeworms could trigger them, other immune system, other infections could trigger them as well. Okay, cool. So let me do this. I'm gonna hang up now, and maybe we'll do chit chat as well. So there's another question. Jana says ivermectin causes brain damage. So yes, Jana, if ivermectin crosses blood-brain barrier in some patients, so this is the Goodman-Gilman 13th edition pharmacology. In some patients, it can cause permanent brain damage. So that is why it is contraindicated in pregnant women, so that their fetus does not develop brain damage. Young children whose blood-brain barrier may still be developing, and people who have active compromise of the blood-brain barrier, for example, meningitis, MS, and so on, strokes. Cool. So please do me a favor. Please like, subscribe, and share. There is a question. Dhruv Chan says, would you cover which wax is better for similar autoimmune conditions that's stable at? Yes. So I would try to do that as well. So thank you very much. Please do me a favor. Please like, subscribe, and share. And if you would like to support this kind of work, there are links in the description. You can buy me a coffee, or you can use PayPal to support this work, or you can be a patron. Thank you, and I would see you in a few minutes in chit chat.